So we're gonna start with our code drugs. Help me, Lord. Okay, so what are code drugs? It's not a hard question. So like drugs we give in a code. Good. Yeah, yeah. And when do you code someone? When do you call a code?
When you find them unresponsive?
Yeah, they're dead. You only call a code when they're dead. You call a rapid when they're almost dead.
Oh, okay.
Okay, so if y'all are on exams, and this will help you in all your exams, you too, because they'll give you a patient situation, then say like, what do? You call a code when the patient is dead, meaning there's not heart rate and there's no respiratory rate. That person is dead. A code means we're basically bringing them back to life. Rapid response is when like this patient is about to be dead. I know because they have like a massive pulmonary embolism or they're projectile vomiting blood, right? That's a ruptured esophageal varices, like something where I know that this is not going to go well and I need a bunch of people to come in and help me, but the patient's not dead. If you call a code and the patient's not dead, everyone's going to be mad at you because the entire code team is going to respond. So they better walk in there and that patient better be beep. Okay, if they walk in there and the patient's like, can I get, I'm not feeling so good. This is not a code situation, sir. You understand? Okay, so that's the difference between a code and a rapid. Do we understand what to do? Okay.
Would it like the people who were caught for cold try to be there faster than rapid, or
Will the people for the code be there faster than rapid?
yeah?
No, it'll be about the same because depending on which unit that you work on. Now, if you're in an ICU unit, usually your code team is on your unit. Okay. If you're on a med surge floor or something like that, you don't have a code team there because your patients don't usually code. They're coming from all different floors and usually rapid is as well. So you're going to get about the same response. Okay. All right. So from here on out, most of them are going to follow this format. We didn't do that for antibiotics because it was just antibiotics are just a totally different thing. Okay. So for each one of these, you're going to have the drug, the class, what's the mechanism of action, side effects, which means what? Expected. We can do something to treat it. We don't usually report them. Adverse effects. No, they're still expected. This we know they could happen, but we have to call the physician. Okay. And then nursing care. What do I do for these drugs? Are you ready? All right, so we're going to start with atropine, okay? Atropine is the only drug that just increases heart rate, and it doesn't do anything else. There are no other code drugs like that, okay? That's very important to note because when we start going through all our code drugs, now some of them aren't on here, like epinephrine, y'all know that's a code drug, epi. Norepi, that's a code drug, right?
You said that increases
Just heart rate. Okay. All those other ones, epi, norepi, all of that is going to increase heart rate and blood pressure. So if I'm just looking to increase the heart rate, I'm just going to give atropine. Okay. And who would I need to just do the heart rate for?
Anyone with bradycardia.
Yeah, that was easy, right? Okay. So if they have severe bradycardia. Now, a lot of people have bradycardia and they're living their best lives out there, right? Okay. So when would I know to give atropine? Like, don't you know some athletes have a resting heart rate of 48 and I'm not shoving atropine down them. So how do you know when to give it? But even then, some people can be chilling, right? Like, am I going to call a code on somebody with a heart rate of 40, but they're like, hey, can I see what's on the menu for today? You see what I mean? So how do you know?
when they're unresponsive.
I mean, yeah, I probably would. But all right, so follow this through. If we're giving it for bradycardia, then what's a worst case scenario bradycardia? What could happen to that patient?
Going to coma like state.
I mean, maybe eventually, but
Oh,
okay, if their heart rate is like 25, okay, what's happening to their heart here?
They can't pump.
So their cardiac output is going to be very low. So what am I going to look for? Signs of poor perfusion. Because where does your body shunt away from first? Arms and legs. And so give me signs of poor perfusion. Y'all need to write these down. This is the basis of the entire cardiac module. What are your signs of poor perfusion? What are they? Give them to me. How would I assess? If I said, Marby, go into Mr. Jones' room and assess for perfusion.
His oxygen saturation.
Maybe, but that's not out here.
Okay.
I'm looking to see if he's shunted, right? Because if he's our shunt, that means like we're already getting poor perfusion,
Pale.
but that's still central.
Yeah.
We're looking for signs of poor perfusion.
Cold or hot?
Okay, so very cold extremities.
Oh, their
Cap refill is high, it's increased.
delayed.
Yeah, okay, so be greater than 3 seconds.
Oh, there's no pulse?
Well, if there's no
Or
pulse, then,
it-
that's
No, I
fine.
mean,
Weak pulse,
Weak pulse.
right? They'd have like weak, thready pulses, or maybe they started modeling already. That modelly look that we know that they have shunted. Yeah, it's like that kind of bluish, but like kind of red. Like when they get really cold. Okay. Like some people's legs do that when they get really cold, right? So those are called signs of poor perfusion. What does that tell me, my patient? They're not getting enough. There's not enough either blood or oxygen or something, and they've already shunted from arms and legs. What's the next step after that? Which is shock. So I need to check that in all of my cardiac patients to make sure their cardiac output is good and they have good signs of perfusion. They're warm, their pulses are regular and steady, right? Their cap refill is less than 3 seconds. You understand? Signs of poor perfusion is what you're going to answer. And remember how I tell y'all, like, sometimes when we're in class, I'm like, if you have to guess, you're going to guess the liver because most of the time it's a liver. If you're going to guess in here and I ask you a question, it's going to be signs of poor perfusion. Okay? Because what's the whole goal of the heart? What's its job? Pump blood to the rest of the body. Okay, so all these cardiac drugs, we want to make sure you're getting blood pumped to the rest of the body. You with? All right, so atropine, what's its job? Increase heart rate. All right, how does it do that? It is what we call a muscarinic antagonist. Okay, so muscarinic is the same as what we call a cholinergic. What is not a cholinergic? Just hold with me for just a minute. What does the term cholinergic mean? What's your keyword? Cholinergic. Okay, let me ask the opposite. What's your keyword for anticholinergic? Okay, let me just tell you. And then, what'd you say? Yes, that's right. So anticholinergics dry you out. So the word cholinergic, it would make sense that the term for that, it would be wet. Okay, so cholinergic, your keyword is wet. Anticholinergic, that's anti-wet, so it would be dry. So in this case, this is a muscarinic antagonist. So muscarinic is the same thing as cholinergic. What did we say an antagonist was? Again, so it's against the wet, which means it dries you out. It's an anticholinergic. Okay.
Muscarinic and cholinergic is pretty much the same.
Muscarinic and cholinergic are the same thing. Yep. Okay. All right. So MOA blocks the muscarinic receptors, and if muscarinic is the same thing as cholinergic, it's blocking the wet, which means it's going to be dry. So atropine gives you a sympathetic response. What happens to your heart rate in these sympathetic? That's a fight or flight. So it's going to increase your heart rate. So of course the side effects would be tachycardia. That makes sense. Dry mouth, also known as xerostomia, because remember anticholinergics. What's your keyword? They dry you out. Constipation, dry eyes. Mydriasis is the dry eyes. Okay. So y'all have heard the rhyme before. Can't see, can't spit, can't pee, can't shit. Okay. That's what anticholinergics are, right? Can't see, causes dry eyes, right? Can't spit, dry mouth. Can't see, can't spit, can't pee, urinary retention. And y'all know urinary retention is always a red flag because what can happen if the patient absolutely cannot pee? Urinary retention is happening only in the bladder. There's nothing wrong with their kidneys. So what happens if that bladder keeps filling and filling and filling and filling? It will burst. So urinary retention, if the patient absolutely cannot void, that is a giant red flag. What's the first thing you do for urinary retention?
You're gonna want to do straight tap.
Way before that.
Oh,
We will get there, but how do you even know if they
you're
have
gonna
it?
want to,
Palpate first. I'm going to palpate, be like, oh, dang, that is very firm and very enlarged. Second thing you do,
is get the Doppler to
the bladder scan. Bladder scan. And then you're like, oh, there's 800 mLs in there. Number 3,
You're gonna want to do the straight tap.
yes, you're going to call the doctor to get an order to straight cat that patient. Okay. So that's where you see urinary retention in this class. Actually, in all classes, urinary retention is a red flag. What is photophobia? Like the light, what to light?
Like
Yeah, sensitive to light. That's because we got dry eyes, right?
Yeah.
And increase IOP. What's IOP?
Cranial.
Oh, you're thinking ICP. What's IOP? Follow the same thing though. If ICP,
pressure.
yes, intraocular pressure. That's glaucoma, right?
Yeah.
And then anhydrosis. What does hydro mean? Water. What does A or AN mean? So that's when you don't sweat. You can't sweat. Now that sounds nice because we don't have sweaty pits, right? But when somebody cannot sweat and cool their bodies down, that can be really, yes, they can't get some of the heat. Okay. So nursing care. Increase FFM. What's FFM?
Female. 40.
Oh, no, you're thinking gallbladder. I know exactly what you're thinking of. It's what we always do for constipation. What do we do? Increase
Fiber.
fiber,
Decrease fat.
fluids, and mobility. So FFM is fiber, fluids, mobility. You'll see it 1,000 times in this class and adult too as well. All right, report the inability to void. That is important. You can use artificial tears, artificial saliva to help with the dry mouth. We're going to increase their fluids to at least 3 liters per day. Keep them nice and wetter. Okay. Do not give to glaucoma patients. Why would you not give atropine to glaucoma patients?
Because it already has, like, it gives the side effect is dry eyes.
Yes, but follow that through. Go to the adverse effect.
Oh, with the
What is glaucoma?
ocular.
Intraocular pressure. So you definitely don't want to do that.
Make it more.
That's right. All right. And then do not give to asthma patients. Why would I not give atropine to asthma patients? Do we want our asthma patients dry?
No.
No, we need everything wet so that way they can cough up all of that mucus. Okay. We use atropine as a code drug. It's used IV push in asystole. What's asystole?
Is that when the heart, when it
Oh,
when the patient's
it's
Asystole is there's
no.
flatline means there's no heart rate at all, nothing. So when the patient has died and they have absolutely no heart rate, you cannot shock asystole because there's nothing to shock. Okay. When you shock a patient, it's just rerouting their electrical activity. If there is no electrical activity, you cannot shock them. So we push 2 drugs in asystole, atropine, and then we go to the other one. And then we go back to atropine, and then we go to 2 drugs. There's only 2 drugs we can use in asystole. Y'all know it. We've said it 1,000 times in here. No. You're going to give them a massive, like you need to give them a massive fight or flight.
Oh, epi, no.
Yes, epi. We're going to give epi. So we alternate atropine, epinephrine, atropine, epinephrine, and we keep doing that until either the patient's heart rate comes back or they die. That's it, we call it. Got it? All right. So in atropine, you'll see I underlined A in the T. Okay. So in atropine, what's the A for? It's an anticholinergic, and the T causes tachycardia because its job is to increase the heart rate. Yeah. All right. Next drug is adenosine. Anybody in here Grey's Anatomy fan? Nobody ever watched it? Oh. Okay, well then I'll have to tell you what happened. So there was a very, very important character in that show. His name was Denny, and he was like in love with one of the resident doctors there, right? And it just like followed their whole love story, and they fell in love, and it was like just this like passion, blah. But he had heart failure or something, and he ended up getting an LVAD where they have to put in like it's like a fake left ventricle. But he wanted to die, like he wanted to let it go, and so the girl that he was in love with came in and he was like, please just let me go. I don't want to live like this. And she cut his LVAD wire and he died. Anyways, his name was Denny. And that's why I told this story because adenosine, Denny, how did he die? She cut the wire and the heart stopped. So what does adenosine do? Stops the heart. Okay. It stops the heart completely. Okay. I know y'all probably, well, no, maybe not. If your computer is not acting right, what do you do? Turn it off and turn it back on. And that's what we're doing to the heart. We're like, your heart acting funny.
Oh,
and so, yes, we reboot the entire heart. We're like, we're just going to turn the whole thing off and then hope it restarts and acts right. It's kind of scary, right? Okay. So it's what we call an antiarrhythmic agent. It decreases the electrical activity in the SA node. What's the SA node? Sinoatrial, and it's the very beginning of the electrical activity of the heart, right? It goes SA node, AV node, bundle of His, blah, 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 right? So, and remember, it's like a telephone wire. So if you cut one of those, there's no more electrical impulses. So if it stops it at the SA node, there's nothing, okay? And it inhibits the cyclic AMP-induced calcium influx. What that means is there are 2 electrolytes that switch in the heart. What are they? Excuse me, there are 2 electrolytes that switch in the heart to give you electrical impulse. Potassium and calcium. So burp, 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 you have to have that in order to make a heartbeat. So if it's if it stops the calcium, then it can't beat, right? Because it's stopping that twist, right? All right, so side effects of adenosine. Sinus Brady. Well, you think we're trying to stop the sucker, right? So yeah, hypotension, that would make sense if your heart is not pumping. There's no blood coming out. Yeah. Okay. Facial flushing. So your body is going to attempt to vasodilate to try to get blood flow to your body. So they may have some facial flushing. That's the least of our concerns at this point. Okay. Chest discomfort. Think it would hurt if they completely stopped your heart. Yeah. They were like, sorry, this might feel weird. Okay. Adverse effects is asystole. Yeah, that's the whole purpose of us giving it, right? Okay, cool. Bronchoconstriction. Why would they get bronchoconstriction? That's wild. When we talked about atropine, that's more of like a fight or flight response, right? Increases the heart rate. Adenosine is more like a parasympathetic response. And in the parasympathetic response, remember the bronchioles go back and constrict because they were dilated in fight or flight. So who would we never give adenosine to? Asthma. Very good. Okay. Or COPD. Okay. Because we don't want them to bronchoconstrict. Okay, so here's how you give adenosine. You are going to find the port that's the closest to the patient. You know, on the IV tubing, you have a bunch of different ports you can push things in. You know what I'm talking about? The little ports, and you can stick in there like this. You want to find the one closest to the patient. Probably going to be on their hand or right here. The one that's like right there that you flush. Because you don't want to push it way up here and then everybody just waits for it to go down the IV line. We ain't got time for that. So you're going to find the port closest to the patient. You're going to slam it as hard as you can because I need it all to go to the heart at one time to stop it. You with? Okay. Make sure that if you are slamming adenosine, you probably want to have a crash cart available because what if the heart doesn't start back up?
Why would you give it to a patient?
Oh, this is the drug of choice for SVT. What is SVT?
What? I know the one part is ventricle.
The V is ventricular.
Tachycardia.
Tachycardia. Supraventricular tachycardia. So what does supra mean? Above the ventricles. What's above the ventricles? In the heart. What's above the ventricles? Yeah, the atria. So this is actually an atrial dysrhythmia. And just so y'all, in case we haven't covered it before, you don't know, atrial dysrhythmias are not usually dangerous and we're not panicking. Ventricular dysrhythmias are bad because that's pumping out blood to the whole rest of the body, right? So in SVT, we will plan this, right? We're like, hey, we're going to go ahead and give some adenosine. So we've already called the physician. We get the crash cart. This is not like, you know what I mean? All right. So important to note is that adenosine has a very short half-life. So knowing that the half-life of adenosine is 1.5 to 10 seconds, that's a pretty short half-life. But of course we would want that because we don't want their heart to stay unstopped or stay stopped. So how long will this last in their body? Knowing what y'all have already learned about half-lives.
A minute? No.
How do you calculate that? We did it. So you're going to do 1.5 times 4, which is 6. And then by 10 times 4 is 40. So that heart will stop somewhere between 6 and 40 seconds. And then you're just going to be like, that it comes back. Okay. Of course, they have to be on an EKG monitor. I mean, that's a given. Yes. Okay. So we're going to slam this adenosine as hard as you can. And then we're going to follow that with a 20 ml bolus to make sure the whole thing went right into the patient. Okay. All right. The dose is 6, 6, 12. Okay. Some places will say 6, 12, 12. And what I mean by that is you may push 6 really fast and then we wait and we're looking at the EKG and nothing happened. So we're like, that didn't work. Let's try another 6. Let me try another 6. Dang, that didn't work either. Let's double the dose and then we do 12. Okay. Some hospital protocols will go 6, 12, 12. Do you understand what I'm saying?
Okay. Would you ever, like, if the patient is too much, then you accidentally, tell them?
Yes, that's why you have to have the crash cart. Okay. So if you gave it and then their heart did not start back up, then you would do a code. So if, sorry. What?
If you give them the 6 and it doesn't do nothing, but then you give them the other dose, and it doesn't do nothing, but then it does do something. I guess that's what I'm asking.
But then what do you, what?
I don't know. Never mind. I'm thinking maybe if it's too much, like
if it's too much, then their heart would just stop and it wouldn't come back. Then we would have to code them. Okay. Is that what you're asking? Yeah. Okay. So if so say you gave 6 and maybe their body didn't catch up with it again. You gave another 6, then you're like, oh shoot. Then after the 40 seconds, they wouldn't start back up. So we would automatically just start coding the patient. And what drugs would you give if their heart was not working at all? Nothing. Atropine and then epi. And then actually, you see what I mean? So we would have to restart them basically. Okay. All right. If the patient is taking dipyridamole, which y'all haven't had that drug yet, but just know it for now, or carbamazepine. Y'all have seen that one? Yeah. What was carbamazepine? Anti-seizure drug. Then you're going to decrease it to 3 milligrams. Okay. We would do like 3, 3, 6. Okay, because there's interactions between those two. I told you you're going to see all those drugs as interactions. Told you it's coming for you. All right, do we understand adenosine? What does it do?
Oh, this
Stops the heart. Okay. All right, next one is amiodarone. Y'all have seen this one before too, right? Dipyridamole is a antiplatelet. Okay. All right, amiodarone. We call her Amy. Amy likes to smoke weed a lot, right? This one's weed for the heart. Okay.
Yeah.
What happens to your body when you smoke weed? Yeah. So what does this do to the heart?
Relaxes heart.
Yeah. So the heart, instead of being like boom, 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 it's like
Oh, you call it weed for the heart.
buh, buh, buh. It's like a major relaxer. The drug class is actually called a potassium channel blocker, which would make sense because if we're blocking potassium, then you're not going to have the boop, 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 right?
Yeah.
All right. We call this weed for the heart. Do you know who Amy Winehouse is?
Yes.
Okay. And how'd she die?
What drug
They
overdose?
tried to make her go to rehab, and she said, no, no, no. It's a song. I didn't just make that up. She's looking at me like, oh, shit. Okay. So, yeah, she had a major drug issue, and I'm not making fun of her. Of course, I'm honoring her because she was an absolutely fantastic artist. But anyhow, this is Amy. So, Amy smokes weed a lot. Yes. All right. So, if this is slowing the AV conduction, prolongs AV refractoriness, which means they don't even really want to talk to each other, the atria and the ventricles. They're just like, and they giggle a lot. Okay. So, of course, the side effect would be sinus Brady, right? What's the first thing you do if a patient has sinus Brady?
Slow heart rate?
We've already covered it
Oh,
today, and I
then
told you if you have to
atropine.
pick something, what's the first thing we would do? You need to assess them
Oh,
first.
the perfusion.
Signs of poor perfusion. If they don't have signs of poor perfusion, we don't need to give them anything.
Yeah.
But if they have signs of poor perfusion, then yes, I would give them atropine. All right. And some people can cause blurred vision. What happens when you smoke? You ever seen people look like this when they smoke? Yeah, because it causes blurred vision. Okay. Hypotension would also make sense, right?
Yeah.
Sometimes it'll cause anorexia, nausea, vomiting. Sometimes they'll puke. Okay. All right. Adverse effects. When you smoke weed, where does it go into? Into your lungs. This causes pulmonary toxicity. Okay. It can cause an AV block. What's an AV block? What does the A stand for?
Atrial ventricular.
Yeah. So that means the atria and the ventricles are just not even talking to each other. The atria is like boom, boom, and the ventricles are like boom. Okay. So they just do whatever they want. They're not talking to each other. Photophobia. The bright light hurt. Why can't we live like this, right? Blurred vision. Turn the lights down, man. Right? And then of course when you smoke, CNS reactions, right? We know it can kind of make you a little loopy. All right, amiodarone, no big deal. Half-life of 25 to 110 days. If you've ever smoked marijuana and then you have a drug test coming up, you should know it lasts in your urine for a very long time. Okay, I'm not asking anybody to admit anything. How long does this drug last in your body, knowing the half-life is 25 to 110 days?
400 days?
100 to 440, right? Because we multiply that times 4, right? Okay. So we're going to do a baseline chest x-ray and PFTs if we're going to put them on long-term therapy, because this can be used as a code drug, but some people actually go home on this drug. Yeah, I know. So I want to make sure that their chest is all good before they smoke the weed, right? This drug does interact with grapefruit juice and diuretics, so you can't give it with either. And that would make sense for diuretics, because if it already causes hypotension and then you're giving them a diuretic, it can drop their blood pressure too low. And amiodarone interacts with everything. It was on our P450 list,
Yes,
wasn't
it
it?
was.
All right, so you already knew that was coming, right? Was it an inducer or an inhibitor?
It's an inhibitor.
Yeah, right?
Yeah.
Yeah. Okay. All right. You're going to watch their EKG. That's a given, right? So what do we use amiodarone for? Who would you need to chill out? Well, if the patient's in VFib, what's VFib? Fibrillation was going zzz, 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 zzz. So of course we're gonna be like, hey, chill, bro, right? And then you got AFib, which is on the top, and that's when the atria is going zzz, 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 zzz. So again, we're gonna be like, chill. Or unstable VTAC. Unstable VTAC or ventricular tachycardia is a hop, skipping, and jumping away from VFib. So we're gonna tell the ventricles or the atria, whichever one, to be like, hey, man, calm down. Got it? All right, the next one is dopamine. I wish I didn't cut it off at the end. I'm sorry. Dopamine. Now, we're going to learn dopamine in other places. Well, dopamine does a bunch of different things, right? Where is dopamine made and absorbed? In the gut. And what's its keyword? Pleasure and reward. But in this case, this dopamine is not the pleasure and reward per se, okay? This is a sympathomimetic. What does a mimetic mean? What does a mime do?
Mimic.
It mimics. So it mimics the Sympathetic system. What happens in the sympathetic system?
Maybe it has been compromised.
Everything goes
up.
up in the sympathetic, right? Sympathetic
Yeah.
means increased heart rate, increased blood pressure. So guess what we use this drug for? To increase heart rate and increase blood pressure. And it causes increased contractility of the heart. So it makes the heart pump harder, right? It also causes renal vasodilation. What does that mean?
Is that where it opens up something? No, where the
Yeah, vasodilation. It opens the renal. It opens the renal arteries. Good. It opens the renal arteries. Now, why would you want to give your kidneys more blood flow? What are we trying to prevent?
What are we trying to prevent?
What do you call it when your kidneys don't get blood flow?
Shock.
Shock. So what is this drug treating?
Shock.
Shock. Okay, so we use dopamine to treat shock, but it also increases contractility of the heart. So what do we also use it for? Heart failure, because heart failure, blah, 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 right? It doesn't pump very good. Yeah. Okay. So side effects: tachycardia. Did we not see that coming? It's a sympathomimetic. Okay. Polyuria. What's polyuria? Well, that makes sense too because it caused renal vasodilation. Adverse effects: tachydysrhythmia. So it can make your heart go so fast that it can cause a dysrhythmia. Okay. Hypertension makes sense because dopamine vasoconstricts. Okay. Peripheral ischemia. What does ischemia mean? Yeah, stop a blood flow peripherally. Dopamine is so intense in its vasoconstriction that it can cause your arms and legs to turn black and we have to amputate. So you better watch arms and legs, right? Signs of poor perfusion when you're giving dopamine because it is such a potent vasoconstrictor. And then there's angina. What's angina? Chest pain that is cardiac related because of the vasoconstriction. Okay. So when you got a patient on dopamine, it does come, it's a drip. This is like an ICU drug that we would be giving. It's on they're on a dopamine drip. So we've got to have them on a continuous EKG, obviously, to make sure they're not getting dysrhythmias. Okay. We're going to watch the BP, which will go which way when you're on dopamine? Up. Heart rate. Up. Urine output. Up. You need to monitor the 6 Ps. What are the 6 Ps? Pain, pallor, paresthesias, paralysis, poikilothermia. Therm? What does therm mean? It says freezing cold. If all of a sudden their foot is cold, yeah, I got a problem. Yeah? Did we get them all? Pain, pallor, paresthesias, pain, pallor, paresthesias, paralysis, poikilothermia, and how would you assess perfusion in somebody? Yes. How do you assess peripheral perfusion in somebody? I done already told y'all 1,000 times. Oh, that starts with a P. So pulselessness. If all of a sudden you check the pulse on their foot, they ain't got a pulse down there. Isn't that a red flag? All right. If any of the 6 Ps are ever present in all of nursing school, what do you do? What? They're not coding. They're not dead. Just their leg is.
You might want to contact the
Yeah, you're gonna call the doctor because they have a dead leg, and if we don't act pretty quickly, we're gonna just have to cut it off. Okay. All right. Do not give MAOIs with dopamine. Anybody know what MAOIs are? Maui. Have you not done psych drugs yet? Okay, you need to do psych drugs. Is it not on your first test?
It is.
Oh, girl, you better get on it. Yes, mono. I mean, yeah, monoamine oxidase inhibitors. Anyways, MAOIs are psych drugs, and they interact with a whole bunch of different things, but they can also vasoconstrict. So you don't want to give those two together. All right, so what do we use dopamine for? We're going to use it for severe heart failure because dopamine increases.
Oh, the heart rate, blood pressure.
But I need what specifically for heart failure does it do? Contractility, because heart failure is poor contractility, right? And then we also use it for shock. Why? How does dopamine get used for shock? It does two things.
Increase the
Renal vasodilation and how did somebody go into shock in the first place? That's a sign that they're starting to go, but that's not. How did most people go into shock? What happens to them? Their kidneys will shut off because what? Why would your kidneys die? They don't have any blood. This usually is a hypotension issue. So dopamine vasoconstricts, which helps to raise the blood pressures. They get enough blood pressure, and then they're opening the vessels to the kidneys so they get enough pressure and blood. Yes, exactly. All right, do we understand dopamine? What does dopamine treat? Heart failure and shock. Very good. All right, now we're going to go to its friend, dobutamine. D-O-B-U-T, dobutamine. Super annoying when it does that. Dobutamine. So dopamine sounds a lot like dobutamine, doesn't it? Okay. And they are very similar. They sisters, okay? So dopamine and dobutamine both increase beta 1. Where are your beta 1 cells? In the heart, okay? So for dobutamine, it activates beta 1 receptors, which will increase contractility. It will also increase heart rate and blood pressure, but very mild, okay? So dopamine is better for like the heart rate and blood pressure, and dobutamine is better for the contractility. If its main job is to increase contractility, then what disease does it treat? Heart failure, okay? So of course the side effect is going to be tachycardia. That makes sense. Hypertension, angina, arrhythmias. We already saw that with dopamine, right? So again, patient's going to be on continuous EKG. We got to watch the heart rate and blood pressure. And this is also on an IV continuous infusion. And you as the nurse will go and titrate. So like if their heart rate is too low, their blood pressure is too low, you're going to look at it and be like, beep, 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 push it up a little bit. And then you just document that you increased it. Okay. Or if you go in and their blood pressure is too high, you'll come down. That's what titrating is. And that's your job, not the doctor's job. They order the medicine and you have to titrate. Do you understand?
Oh, you just titrate according to the heart vitals.
Yes, to the vitals. That's right. Okay. So dopamine is better for shock. And dobutamine is better for heart failure. Do you understand why? Do we understand the code drugs?